A very good evening and welcome to one and all to the series of webinars organized by our prestigious Dental Council of India. Today's webinar is the 21st in the series of webinars organized by our council. It is a great initiative taken by our Council of India, especially during these COVID times. Here, I welcome you all to the DCI platform for virtual learning. There are few instructions, important instructions for the attendees. Kindly follow. At the time of registration, complete and proper details must be furnished since the same will be captured for generating certificate and CDE points. No request for any change or modification in their details shall be considered. An e-certificate for attendance will be emailed to all attendees on their registered email. CDE points will be awarded to the dentists registered with state dental councils, tribunals of India. Certificates will be sent to the attendees by email within 3 days of conclusion of each webinar who have attended the entire session of webinar uninterrupted. Please check your junk email folder just in case the certificate of email is not delivered instead of in your inbox. In case of any query, any issue, please drop a mail at webinardci@gmail.com. If any one of you missed any one of the DCI previous webinars, the same can be watched on DCI webinar archive on DCI website. Kindly follow. And your feedback is most important to our council. The feedback link will be sent to you with the certificate email. Kindly go through and give the feedback in time. It will be highly appreciated. And there are a lot of colleges took part in our webinars in the past 20 webinars organized by prestigious Dental Council of India. Out of that, 5 colleges have the highest number of attendees have come from these 5 colleges. Those are Savita Dental College and Hospital, Chennai, Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, Jan Naik CH Devilal Dental College, Sirsa, Saraswati Dental College, Lucknow, Mahatma Gandhi Missions Dental College, Navi Mumbai. We really appreciate these 5 colleges for attending a large number and making this webinar a huge success. It's not that all the other colleges have also participated in this, but these 5 have a lot of attendees have attended. Now coming to today's most important session, the webinar, the speaker is none other than Professor Anmol Kalha, sir, who doesn't need any introduction, but it is my responsibility job to introduce sir. Sir, Professor Emeritus, Distinguished Professor and Advisor to SITS, Associate Director and Advisor, Max Healthcare, Chief Architect and Co-Founder at Mednova, Chairman, Scientific, India International Orthodontics Symposium 2021. Not only these academically, Sir was captain of college team, lawn tennis, 4 years, champ, and he represented Punjab University and state also, Secretary of English Literature, took part in a lot of debates and represented the university at university level. And with this, I request Sir to please take over.
Thank you so much. At the outset, ladies and gentlemen, good afternoon. And it's a cold, wintry afternoon in Delhi. And I'm so grateful to the Dental Council of India, the EC. And I think I would be failing if I didn't mention my very dear friend and close colleague, Dr. Anil Chandna, who literally pushed me into speaking on evidence-based orthodontics. It's an interesting concept, and having been there at the center of it for about 2 decades, I have some thoughts to share with you. I'm also very grateful to Dr. Srikrishna, the President-elect of the Indian Orthodontic Society, for having given me these, this sort of kind words. And I'm most grateful that he didn't disclose everything he asked me about my undergraduate days and my college days. So I really owe him one on that. I'm very grateful to Mukesh ji. It's been a pleasure to interact with you after so long, and of course to Virendra Goyal. So let's talk about the topic at hand today. And it's with a little bit of regret that I come and I open my conversation with you on evidence-based learning, because about in the year 2000, I sort of got involved into it. But we've been through some very unprecedented times. And if you look at the past 1 year or, from March onwards, it's been a time of silence. It's been a time of reflection. It's been a time where the world has shared commonalities. This pandemic has brought us close to ourselves, and it has given a lot of time to reflect. And I, for one, did find myself thinking that, where are we with orthodontics? And where are we going? What's the future? Interesting perspectives, because the beginning was very, very radical. And by early 2020, I was very upset. And I wrote in the press and the media that the easiest thing for any regulatory body in this country to do was to just shut down dentistry. To say that, listen, it's too dangerous. The patients can live on antibiotics and you don't need it further. There was a concern because the oral cavity was an incubator and high viral loads are found in saliva. And I'm very glad to notice that, a year down the line, I really have not been able to pick up a single case where the transmission took place from the clinic or from the patient proximity. Orthodontics became inessential, and it really did add to the stress of people sitting at home, and there were financial and many other implications that came about. More than that, I think when you look back, I saw the very large segment of webinars that came our way, and I couldn't help thinking that here we are revising whatever we did before. We just went back to it. We spoke about brackets, we spoke about wires, we spoke about techniques, the best way to use a bracket. But it was a year that brought us back to our fundamentals, and so many things that we considered necessary were expendable. Here we sat at home, fairly comfortable 9 months later. And the question was, as orthodontists, as members of this profession, whether as clinicians or as academicians or as leaders or as followers, did we look at ourselves? Did we reflect on orthodontics? Because, as I've made a point here, habits feed on themselves. It becomes a point of inevitability, and the silence of pandemic, it just proved their futility. The question now in 2021, as the vaccine has come, and yesterday was V-Day, do we shed the habits of the past and begin anew, or do we go back to the old ways to repeat the past without reflection? I think from that perspective, let me just go back and talk to you a little bit about entropy. And this affects everything in the world. It's things tend to break down, wear out over time, and everything tends to look at, it's like that house there. How many times can you repair it? And when you start looking at orthodontics, and this was my thought, and I hope you share it with me, that the pandemic would have accelerated this transition, that did we need to change orthodontics? And I'm going to make a candid statement here. It may sort of upset a few people, but, well, that's what this whole story is about. And I am a little disappointed in myself, and because I started this movement way back in 2000, because evidence-based orthodontics was supposed to have replaced eminence-based orthodontics. It was supposed to have transitioned this entire story from evidence to eminence to expert-based to opinion-based orthodontics. And here we are, ladies and gentlemen, right at the back, where our profession today is controlled by opinion, eminence, and the business of science. There is a new science in orthodontics which is called the business science. And this trumps everything beyond patient health. I'm going to develop on this, I'm going to dwell on this, and I'm going to share my journey with you on the evidence-based story and what it meant to the world. Did we really succeed or have we failed? And it brings us back to that same single question, that do we have a scientific foundation for our decisions? Because there was a big challenge when we started looking at evidence. I think the whole concept of evidence came in 1980s, and Sackett has written extensively, and evidence-based dentistry made its entry in 1995. Derek Richards is a great friend, and I went to the Radcliffe Infirmary in year 2000 to get trained with Derek and to understand what it's all about. And frankly, the initiation or my introduction to evidence-based orthodontics came from the the guest lectures at the Armed Forces Medical College, Pune, which had a great precedence that everybody attended, all faculty members, everybody attended a lecture. And I, somewhere in 1998, before I quit, I heard this lecture, which was hosted by the Department of Hospital Administration. It somehow stuck with me that, is there a way out? I mean, do we just have to follow people without having a foundation? So I went and trained in 2000. I came back. We set up a center in 2001 with Derek Richards. Aspon Yoxard was the science manager of the FDI, and we got involved with the vice chancellor, and we held the first national conference in Davangere, which was called Training the Trainers. And the vice chancellor, Dr. Chandrasekhar Shetty, was a keen proponent, and he had us lecturing to all faculties, to nursing, to senior physicians, and we ran these series of workshops trying to create a movement that, look, guys, could we just sort of base our decisions on facts rather than going sort of with opinion? So let me just dwell on this a little bit, because there will be some postgraduates here, and this matter is lost because in the last 9 months, I haven't heard anybody speak about basic science or skepticism or healthy questioning, because that's the way we teach our postgraduates. We've been too busy talking about brackets and philosophies and wires and trying to teach people that the best way to do it is this way, and who cares about science, because teeth move and people pay money for it. So what's evidence? Well, it became a fashion at one point of time, somewhere halfway down, when we realized that everybody wanted to speak about evidence-based orthodontics or evidence-based prosthetics or evidence-based endodontics, would pick one article and then quote it. But, well, evidence essentially meant a scientific journal reporting results of research which were considered as evidence. But then the question came that not all publications were equal, and they did not have the quality and could not stand to stringency. So the hierarchy of evidence was a natural development. And right at the top was the meta-analysis, and right at the bottom was the expert opinion. And sadly enough, as I speak to you today, ladies and gentlemen, in orthodontics, and I'm not going to comment on other specialities, I could, because I do look at dentistry from a wider perspective. We've inverted the pyramid, because I think right at the top is expert opinion, and we have key opinion leaders who are going to talk about it. I'll come back to that. But so this was the story, but the iceberg of evidence was, it was felt, and somewhere down the line, I got the feeling with my colleagues and with various bodies, including the surgeons, it was very easy to go and speak to the medical professionals. I'll tell you why. It's very simple, because the pathology and the diagnosis of a disease was distinct. I mean, you had a bacterial infection, you had a pneumonia, and you had an intervention, which was a series of antibiotics, and you had an outcome that you got better. But let's talk about orthodontics. Was it that simple? Because you had a complex philosophy behind it. You had multiple factors. You had growth. There were many ways of treating. There were many appliances. And at the end of the day, we had never prescribed or decided that what are the outcomes. And somewhere down the line, the feeling came up that evidence-based dentistry or evidence-based orthodontics is for the academics. The clinician does not have the time or the patience to do it. He wants to get into his practice. And I'm just showing you that this is what was right at the bottom. And what everybody craved for was the clinical application. Well, obviously, we are clinicians at the end of it. You're trying to provide a patient service. And if you do not have answers to questions which is based on the sort of evidence, there is no point. I've shown you the circle of evidence. We went through it all, and there was a simple process or system, and we tried very hard. Personally, I've been associated with running a couple of institutions, and we said, listen, you have to integrate this at the postgraduate or the graduate level, and you need to get them to ask a question. Now, that in itself was a challenge in the Indian context, because the very paternalistic system of education that we practice, which postgraduate student is permitted to ask you a question? But we did run workshops, and I have intervened, and we've tried to do it. That is very simple. I mean, you didn't need to do something fancy. You had a problem or or an intimate population, you had an intervention, you had a comparison, you had an outcome, you could frame a question. Once you framed a question, you could go and look for the literature, and once you found the literature, you could analyze it and apply it to your clinical solutions. Did it happen? But then you found a paper and you suddenly felt that, was this paper going to answer your questions? Well, the truth is that reading a paper in itself was something that we needed to teach ourselves, we needed to teach our students, and trust me, we don't do it today. Well, I've tried my level best, but as I said, in the last 9 months, did we even think critically about diagnostics? No, we didn't. So you could answer the question from a paper, whether it was worth it or not, by just looking at 3 questions. Was the focus of the study clear? Were the patients randomized? I want to come back to randomized controlled trials because they're very difficult to do in orthodontics. And all the patients accounted for. If the answer to 3 screening questions was yes, you accepted the paper, you read further, otherwise you dismissed it and looked for the next paper. Now I'm going to just give you an example here, which confounds everybody, that you take sort of a drug A, there's a control group, there are 100 people, 20 die, and they are given this drug and 80% survive. So is it 80% effective in preventing death? Or is it 100% effective in preventing death? But let's take drug B, okay? You dropped 20% who did not come into the trial and 80% survived. So was it 100% effective or was it 80% effective? I'm just trying to show you that, this whole concept of interpreting evidence, it needs critical inquiry, which unfortunately we don't have the time. So we said, all right, let's take this further. I've been on the board of this journal on the right-hand side, the Evidence-Based Dentistry Journal, since 2000. They've had me there, write commentaries. And so the whole focus on evidence-based dentistry, and I'm not even limiting it to orthodontics because there are a lot of people here. People said, okay, pre-appraised evidence. So the Cochrane Library came up. And it was known for rigorous and stringency methods. And by 2016, you had 22 reviews listed in orthodontics. Okay? And then people like me were asked to write commentaries and meta-analysis and trials with the purpose of defining clinical outcomes. That if you read a paper, at the end of the day, are you solving a problem? Are you giving a direction to the clinician, or are you leaving it unsaid? So that was the same question that I asked myself. I asked my colleagues. They're all around, Shailesh and Subra and the others. We all got involved. Here's my direct question. Did we change the world? No, I'm afraid we did not, because it was the same old thinking. Did evidence transform orthodontics? Ladies and gentlemen, it's an open question. You have a question in our section. I would appreciate your input. The question was, did we change our thinking? Did we even say that we need to question what we teach and what we practice? And we need to find a better way of doing it. Or was it all about technology? Because we seem to have reached a point where the business science in orthodontics, it transcends everything. Because you will have a very learned gentleman who will get up on the podium and say that here is a particular wire or a bracket, and it's going to transform everything. It's going to transform the cellular responses, and teeth are going to move. And this is the only way to do it. You don't need to look at anything else. So this was the challenge. But we went in. And I don't blame people for abandoning evidence-based dentistry or orthodontics, because if you had a systematic review or a meta-analysis and did not answer a question, it was of no value. And then we started looking deeper into it, because out of the 22 orthodontic reviews posted on the Cochrane Oral Health Group, 17 concluded that the evidence was insufficient, that further RCTs were required. So what did you do in the interim? Here were people like us who set up at the South Asian Center in Davangere. We taught it. The university insisted we teach it to everybody across the board, to senior physicians who doctored us. But here was the question, that if all the literature was inconclusive and you could not make a clinical recommendation, was it worth doing in the first place? A big challenge. And then came this story of research waste. And you realize that out of all the research that is done, and I asked this question of so many institutions who are here, and hopefully who are here, because you look at the number of colleges and you look at the amount of effort that goes into our dissertations, and what comes out of it. Because This is a great review which has been written here very recently in 2019, and it says that in 2019, about out of 2,000 orthodontists who were interviewed, 59 found that the literature was was conflicting and unambiguous. And here you have the dustbin of Indian research in orthodontics. If you take everything that gets done on the floor of your clinics, and I want you to go back, I want you to look at it, and I'm so glad the Dental Council is here because we need to rethink this, that 90% of the dissertations are reinventing the wheel. Do we even go down to the cellular level? Do we even explore the frontiers of biology? I mean, I'm asked to pass judgment on synopsis which says a non-extraction treatment with Damon brackets. Hello, excuse me. What did the bracket have to do with the treatment? And what does extraction or non-extraction have to do with the bracket? I'm going to come to that in a little while. But ladies and gentlemen, this is what is called 85% of research in orthodontics is abandoned. It has no value. So where are we? Where did we go? So we reached a point where it was fashionable to talk about evidence-based orthodontics. I told you in between, I sat through with my heads of departments, and I used to find them saying, oh, but this is an evidence-based lecture. They would quote one study, and I would say, excuse me. So please tell me, how can you practice evidence-based orthodontics if you cannot have a control group? Now, can I deny a group of children treatment and not sort of the other group? It doesn't happen in orthodontics. That's one problem. And then there is this huge time interval between the actual treatment decision and you're using an appliance and an outcome. And did we even define what the outcomes are? What are we looking at when we finish treatment? Because at the end of the day, ladies and gentlemen, this is a very, very sad story. And I'm going to stop this here. I'm going to come back to this because class 2 is a burning question in orthodontics. This, ladies and gentlemen, is the first randomized controlled trial published by Jacobson in 1967. And he wrote then that the study does not support the hypothesis that activated treatment can bring the mandible forward and affect condylar growth. Hello, this is 2021, and I'm going to show you the evidence. Did we learn from this? Or did we persist in doing what we are so used to doing? And here is what I said, that why have we subjugated our profession to clubs? Everybody is teaching us, all right? And if you notice, and it's with a heavy heart, ladies and gentlemen, it's 40 years down into the profession, and here is a consistent trend that this oldest specialty is being managed by the industry. We now belong to clubs and groups. We proudly announce ourselves as platinum providers, as a bracket orthodontist, and we have elite memberships. And if you look at it, whatever you teach is now appliance linked and promoted. It's technique focused. It's shocking to me that even at the institutional level, we are more concerned about promoting a technique and say, oh, we do Damon here. Hello, do you do self-ligation or do you do a particular bracket system? I could use 20 brackets if I wanted to, but we take pride in it. So who sold whom to whom? Is this the question? Was this where we were heading, or did we evolve a new business science where the patient doesn't matter, but the profitability exceeds patient care, not at your level and my level, but also at the level of the industry that we do. And here is Dave Sackett, who finally commented, I had to go and make a presentation in Australia at the ASO meeting, and Pete Miles, who was a critic, got up and he spoke about it, and we got into a big argument, and this finally went into a comment, and he said, and Dave Sackett said that historically, orthodontics is driven by gurus, by techniques, by appliances. It's been long on rhetoric and short on hard evidence. 2021 is here, ladies and gentlemen. Are we willing to change this, or are we still where we were several years back? Because I'll tell you something, everybody today is claiming that this new wire is biologically superior and it will do magic for you. But that's an extraordinary claim, and I want extraordinary proof, but the proof is missing. Because it's not required. We are not even looking for it. Ladies and gentlemen, it's rather sad, because this is what has happened to orthodontic education. And I'm sorry, we have very senior people who I presume will be here, and Dr. Srikrishna is here, and I really hope he takes it from here. study clubs have become scientific societies. We share a bracket system, so we have a study club, but it's become a scientific society. Appliance philosophies are the core of elite clubs that I belong to this group, I belong to this group, and the industry is willing to sponsor specific conferences and groups and networks. I'm shocked. You have journals which are in the form of newsletters owned and sponsored by industry. And the doctors display their cases with no records, no critique, no nothing, with great pride that I took this case, I gave it this beautiful appliance, which is biologically superior, and bingo. Listen, ladies and gentlemen, I can cherry pick 10 cases and I can bring you great results. You have conferences within conferences, and Dr. Srikrishna, this is a straight message to you, sir, that you will have a national conference and you will have the trade and you will have a set of people who don't speak inside, but have little booths and are eminent teachers and practitioners and are extolling virtues of appliances. Do we need to have a conference within a conference, ladies and gentlemen? Are we here to extol magical virtues of products? Well, I made this comment to Dr. Anil Chandna. I said, sir, you called me to give this lecture. Nobody's going to invite me again. The industry will shun me and say, listen, you're hitting hard. So this is gone. And this, we need to understand that the industry is driven by business, and it goes to direct to consumer marketing. And today you have a prominent brand of self-ligating brackets and aligners, which they've gone to the common person on the streets. And the internet is redefining. And instead of focusing on the science of orthodontics, our scientific meetings acquire a problem-solving approach. That I know the tips and tricks to use this bracket in the best way so that all your problems are solved. Or I know the tips and tricks of how to read a digital format for an aligner. These are propounded from the pulpit. We have eminent people. So where is this whole story, Dr. Kalha? I asked myself that you went to Oxford, you trained, you went back, you did courses, critical appraisals. Is it lost to the cause of brand building? And if it is, then ladies and gentlemen, why have we not been able to build a brand in orthodontics? I'm really surprised. And here is a very, very fascinating paper, and I want all of you to see this, ladies and gentlemen. And this is the evidence on success. Have you seen the failure in orthodontics, and where does it come from? Have you seen the format there which says that poor treatment, inadequate retention, failure in diagnosis and treatment planning? Hello, ladies and gentlemen, but we never spoke about it in 100 webinars that took place around the world. Problem managed of transverse deficiency, failure of camouflage. Okay, yes, and when you add the unfavorable skeletal growth, secondary malocclusions, TMJ degeneration, maturational changes, airway and obstructive sleep apnea, where you've got a complex situation, because you know what, folks, this is where we are. 97% of cases, and I'm not quoting myself, I'm quoting literature. 30 to 50% of cases show acceptable alignment up to 10 years post-treatment, and barely 10% are stable 20 years hence. So ladies and gentlemen, where is all this development and brackets and whys that have come? Can we only recommend lifelong retention as a permanent cure to orthodontics? Have we failed somewhere in our assessment of what we do and how do we do it, and what we teach and how do we teach it? I'm afraid it's time for a critical self-inclusion, because I'll tell you something, and this is why when I chose this topic, I said, listen, we have to do deep learn, because I'm going to come back. You can't have randomized controlled trials, but today the world and the pandemic has proved, and we are working. I'm very happy to say that I was a part of a startup where the oldest man got invited. We've been working on health analytics. You have to be data-driven. Are we data-driven? I'll tell you why. Because malocclusions are complex. You know, it's not like a bacterial pneumonia. It's not direct. It's complex. It's got ethnicity. It's got age. It's got gender bias. And every malocclusion is a very complex intervention of interaction of genetics, biology, and function. And each malocclusion will have subtypes. So please tell me, how can I promote a bracket or a system which will solve all your problems? You have people who will vary as they age with their craniofacial structure and biology, and one size does not fit all. I think this concept of the bell curve and being right in the middle of the bell curve is something that has failed orthodontics, because you just cannot, because every person you see is an individual, and every individual will need to be treated as an individual. So you're going to ask me, Dr. Kalha, what's the solution? I'll come up with the solution, because the first candid statement I'm going to say is, listen, our profession is not driven by appliances, it's driven by diagnosis. Now, if we can teach that to our students, I think we'll be getting somewhere, because I'll tell you something, you start being clueless, you become confident, and then you become realistic, and then you've achieved it. Did we ever get to achieving it? I'm afraid I haven't. In 40 years, I stand here before you. So where to what and where? So let me make a candid statement here. I'd call it the business science. Manufacturers, ladies and gentlemen, have a responsibility to their stakeholders and not the orthodontists. They need to build brands and advertise because their livelihood depends on it, right? And when we deprive our profession from research and scientific inquiry into clinical practice, it will harm patients and professionals in the long run. We haven't realized it. Accepting and endorsing claims on brackets, wires, appliances, advantages on treatment duration, extraction, non-extraction on an appliance, efficiency on techniques. We need to look at the numbers, we need to look at the depth, and then we need to accept it or reject it. I'm not saying things don't work, but in which case do they work, and how much do they work, and is it worth the cost and the effort that you're putting in to give it to the patient? That is the challenge, ladies and gentlemen, and that is why you see this topic. The world is in the process of transition. The pandemic has proved it. The concept of evidence does not hold good. It has to go to deep learning and data mining. Now, this is the challenge in orthodontics. And how do you get further on that? All right. Here's my thoughts to you straight away. It's not as straightforward as we thought, evidence-based orthodontics, because out of the 22 full reviews, 17 cited insufficient evidence. And if the evidence was pre-appraised, it did not address the issues of the clinician directly. And when you have evidence, it conflicts with clinical reality. So if you go by the English stable or the British concept, then I'm afraid you're going to create a tyranny in orthodontics, because you're going to say, this doesn't work on the evidence, so you can't do it. Okay? I'm going to come up with some specifics, because the orthodontists would be getting fed up. Well, let's take the issue of self-ligating brackets. We've had very serious issues on self-ligating brackets. I myself have been in the center of developing one set of brackets and working it, but I never went and spoke about the bracket. I spoke about how do you use it. But here is what Kevin O'Brien, who writes from Manchester, and he spent his lifetime trying to prove that it doesn't work, ladies and gentlemen. He's just killed it. And he says, and every blog of his quotes the literature, and he says, oh, final nail in the self-ligation coffin, more nails in the self-ligation coffin. So it brings you to think that, listen, are you always looking for proof in what you believe in? Because in England, you don't believe in, or Kevin O'Brien does not believe in self-ligation. So he's going to try and prove to you that it doesn't believe in. And on the other hand, you'll have another speaker who believes in it, will try and prove that his system of things work. But this is what we go through. It's either a confirmation bias or a cognitive dissonance. And this is central to orthodontics. Okay, now here is my take on self-ligation. Now I'm getting into dangerous areas because I'll get hit by cases. I have unconfirmed sources which say that almost 20 million cases have been treated globally with the Diminish implants. Okay, and if you look at all the literature, the effort is to say it doesn't work. The critiques are, oh, it's junk. Why do you use it? Why are you charging extra? But the reality is somewhere halfway down the line, because the doctors and the patients are happy with the appliance. And if your patients were not satisfied and you were not getting results, would you spend the extra money? So why are we branding a bracket without looking at the evidence? This is where the story comes in of looking for numbers. If you don't have a randomized controlled trial, can you accept it or reject it? I'm sorry, we'll have to go deeper than that. Okay. Now here are the opinion-based claims on self-ligation. Now this is what shocks you. This is what goes against, that you find it on websites of the bracket manufacturers, that patient satisfaction is an all-time high, 4 to 6 months reduction in trying, 30% leader lesser composition. And my question is, what was the composition? How many patients were under study? What were the types of cases? Did you consider the complexity of the malocclusion? Was there a bias in the sample? These are questions which we need to ask our students. We don't. We're not training our students to ask these questions. Okay. What you believe in is practice. It becomes a part of reality. It becomes a habit. Because here you have people, and I'm shocked when you go to sort of, students in postgraduate exam, you say, what are you doing? Sir, self-ligation, non-extraction with Damon brackets. Hello. Why are we building the complexity or the entire concept that if you have a self-ligated bracket, you don't need to extract teeth? And this is being reinforced. This is being endorsed. No matter where the sort of the truth comes out that you can tip teeth with standard brackets, you can tip them easier with self-ligated brackets, but you cannot grow bone. There are studies in the angle orthodontics, there are cone beam tomographic studies, there are papers published in everywhere, but it's like the emperor's new clothes. The opinion continues to build the image that you can do more cases, non-extraction, you get better smiles, you use less time than if you use a Damon system. And I'm being very open about it. I'm speaking, people will say you should not say it, but I'm saying it's being unfair to Damon because I said 20 million cases in the world. Why are people using it? Why am I using it? Have we built evidence or have we failed as scientists? Here is a question, as I said, I'm at the other end of the profession. Because I think there is a case for self-ligation, but it's not for faster treatment. There are clinically relevant reasons for using it because you have reduced friction, you have reduced fall levels, you have early activation of appliances, you have a concept of disarticulating the occlusion. Why didn't we think about it? You have a reduced bacterial load on brackets. And when you're looking at reduced visits to the orthodontic environment, well, then there is a self-evident story. But the call for evidence is lost. Why can't we just take all the studies in the world and put them together to understand it worked in so many cases, it didn't work in so many cases? Because we don't need to. Because the industry says it works and we are very happy to accept it. And we sponsor courses and we sponsor entire conferences which take you through, and it is being unfair to Damon because some scientist is going to come in and say, where is it? Here's a fact which comes up that you do have periodontal pathogens on oral appliances. If you use self-ligation, would you drop it? If you reduce forces on teeth, would it be better for external apical root resorption? If you look at occlusion, the rigidity of a full-size wire in a H-piece bracket will tie everything up and it will not permit the occlusion to settle. When you remove it, there will be a rebound phenomena, whereas there is play between the bracket and self-ligated, between the wire and brackets, which would give you a better settling. Okay, let's take this case, and some people, well, I'm very happy to share this. It's come from school. They do a great job, and you can look at this little girl who's got her teeth aligned, and she's got into a class 2 corrector, and then she's grown into it, and then finally you just go gently and you finish it. Now, there's nothing spectacular about it, but neither is the claim that it was only because of self-ligation. I'm sure you could have done it with some other bracket. I'm not denying it. But certainly it reduced the forces, it reduced the level, it reduces the struggle on the chair side, and the patient is okay, right? So here's where we are. And here is what you need to understand, that systems need to evolve and need to be learned and put into clinical practice. And with each appliance, there are nuances, and so it is with David. But can we claim magical properties to a bracket? I'm afraid the evidence does not show. You can, but there's no control. You lose control on torque. You find that the teeth collapse, and it tends to build up. The pro guys are all industry driven. The anti guys are all academicians who spend a lifetime trying to prove that this bracket system doesn't work, and you can't. Extraction cases will collapse. And listen, guys, it works. 20 million cases doesn't say it doesn't work, but the method of promoting it, the method of teaching it, is something which is earth-shattering, and we need to look at it. We need to look at it seriously as clinicians and as people within the profession. That it's a bracket system. If you understand the interplay of the function of the hard tissue, the soft tissue, of the occlusion, and you analyze it correctly and you use a bracket, well, if you know the best way to use this bracket, it will certainly work. But is there a magical quality to it? No, I'm afraid not. But that is lost. Expansion, non-extraction treatment. We've had this long sort of story of orthodontic treatment affecting the periodontium. Does it happen? Of course it happens, because the soft tissue architecture will define the aesthetics of the treatment. Now, do we consider it? Do we quantify it? Do we take it into our treatment planning, that what is the thickness of the cortical bone? What is the bio width of the soft tissue? That is going to tell you whether you can expand or no. It's not just about taking a cephalogram and deciding that you can tip the front teeth out by 3 or 4 millimeters, because there are consequences to it. Because a thin biotype will have thinner cortical plates, it will be prone to dehiscence, and you need to understand where the roots are placed. Do we get into this kind of analysis? If you do, I'm very happy, because if not, then you have to correlate it, but we don't. We don't. And I just want you to see the progress of this case, and I just want you to follow one tooth and watch what happens when you haven't planned it and you haven't understood where the teeth lie and where the roots lie, and just look at that tooth beginning to fenestrate, and it's not going to go back. Did we assess the biotype? Did we look at the cortical plates? Did we look where we needed to position the roots in the center of the cancellous bone for stability? No, because it's a bracket system, and this is where you don't want to keep a patient in, but are you going to send him for repositioning or periodontal therapy? I think this is where that article is so soul searching, that we failed in our diagnosis, we failed in our treatment plan, and we're not the only ones. A recent review I was reading in the US shows that out of 3,000 diagnostic decisions which led to mortalities, 4 to 6% could have been avoided. And I'm talking of fatal decisions. It's diagnostics, ladies and gentlemen. Did we ever have a conference which focused on diagnostics or failed cases? No, we didn't. We've never had it. We'll never have it. We will be happy to talk about brackets. This is where you are. Because you contradict yourself, because you can tip teeth, but that doesn't mean that you can move them out. You have problems with the restriction that the limits of your tissue and your bony structure gives you. The appliances cannot make bone grow. You can't change the genetic makeup of cells. You cannot influence the DNA by using a different wire or a bracket, ladies and gentlemen. It's got to be a complex interplay of forces, and how does it work? So what is it? What defines? Is it the limits? Is it the lack of understanding that we are here in the year 2020? That we our poor treatment continues to be the largest reason for failure in cases? And how many of us do an audit on our cases, ladies and gentlemen? How many institutions do an audit? Do we as a society, as a body, publish on our failures? I've been sort of raising this issue with Dr. M.K. Prakash. Why don't we run a conference where the exclusive entry point is bring in 10 failed cases and discuss them? Tell us why you failed. I hope that'll happen. But this is what it is. So I'm going to ask you this question, that if there is no evidence, do you not do it? So here is the Baridon's paradox, or Baridon's ass. You see that donkey has got 2 equal mounts. Which one should he eat first? Now, this is the challenge in orthodontics, because if it exists or if it doesn't exist, then what do you use? Well, you'll have to start mining numbers. I'm going to come to that. This was started by Aristotle, and it's called Baridon's ass. It says that if you don't know, suspend judgment till you know, but collect data till you know. Are we doing it? We are still not doing it. We'd be happy to stand on a podium and present 10 cases and say, oh, it works great. Forget it. Why it shouldn't? So here is this challenge today, and why evidence-based concepts, the way we know it, are going, because, anything that comes along, you want to know what is the efficiency, what is the effectiveness, what is the predictability of treatment methods, and what are the outcomes. And this would come from studying treatment outcomes with self-ligation. So, ladies and gentlemen, can you just get down to studying outcomes of 500 cases and then compiling the data and seeing what worked, what didn't? No, we're not interested in that. Because if you look at retrospective data, then it can be structured. I'm going to show you some neural networking papers that are beginning to come out. I'm personally working with Dr. Chung at the University of Alabama to get something going on class 2 on this. But this is where the story is. Because the new orthodontics will be patient-centric, non-linear, and you need to choose. How do you choose? All right. Because what outcomes do you measure at the end of treatment? Oh, it's a big question. How do you know you've reached the end? Do you have any specific measures for outcome which you can compare? Well, the papers are beginning to come out, and I'm glad, because this is where it's beginning to come in. And I'm so glad that Kevin O'Brien came in and said that there are 5 or 6 issues that you need to come in. Impact of self-perceived aesthetics, alignment or occlusion, skeletal relationships, stability, breakages, adverse effects on teeth, patient-related areas. Because we cannot just go with research-oriented outcomes based on cephalograms or measurements or models. That patient is a live human being. And when you start measuring outcomes, you will begin to understand why some people are happy with some appliances and some doctors do very well with those appliances in a certain group of patients, and why others don't. Let's take Invisalign. And I'm going to come to it directly because this is after self-ligation, this is the biggest controversy. And even today, as I speak to you, there are a lot of people who belong to the old school who say, oh, come on, rubbish here. How can you substitute the edgewise appliance with plastic? Hello? Excuse me? But what you need to understand is that in 1997, they changed the orthodontic market forever, because it went straight to the consumer. And if you looked at the conversation with the CEO, Tom Prescott, he said 2 clearly stated goals: the shareholders, investments, market share, and straighten crooked teeth. Ladies and gentlemen, is orthodontics only about straightening crooked teeth? Then what is the need for the art and the science discussion that we've had over years? Or can we just go around teaching people that how can you get more out of braces without needing to market yourself? Is that the end point of orthodontics? Because here is the story, and I'm saying it openly. Did Invisalign open the Pandora's box? Because here you are in 2020, the American Journal of Orthodontics went down to look at patient perceptions. Will they define treatment trends? I'm afraid they will. Because cost, convenience, perceived simplicity all appear to factor into the consumer's consideration, because he's on the net, he's on Google, he's being hit by advertisements from bracket manufacturers to Invisalign to say, hello, this is the easiest way to do it. You don't need to go through complex issues. The case may be complex, but he's going to take a call. And this is where we need to be prepared ourselves to be able to take in the new lot of patients, because as the annual income, age, education increases, the patient is likely to consider direct-to-consumer orthodontic treatment. And the industry, ladies and gentlemen, the business science is going to leverage this for marketing and promotion. As a specialty, are we prepared for it? Is dentistry prepared for this? Because in 1999, they arrived and they evolved, and they went into direct-to-computer marketing. And there were some who went into it, and there were some who sat on the fringes and said, it doesn't work, so I'm not going to do it. But there were some changes that took place. And I looked at this paper, which came exactly, a decade later in 2019, after 2009. All you improved in accuracy was 10% with Invisalign, with all the technology. This is what the last study that was published came up, that the maximum improvement achieved by aligners in a decade of research and consistent movement ahead was 10%, ladies and gentlemen. But do they not work? So let me show you complexity. And since I've done it, and I'm not willing to endorse it, I have not shared these cases on the Invisalign platform. I have no intention of lecturing from an Invisalign platform, because I cannot be driven by industry-driven norms that you will present it like this. But here you are, ladies and gentlemen. This is a 21-year-old gentleman who traveled around the country. He had 2 problems. One is, of course, he had the cleft surgeries. He was repaired. He went in for orthodontics twice with fixed appliances, but he said he used to choke, so he used to put it, once he ripped it off at home, the next day he ran back to the orthodontist and had it removed. So he was here. And then he goes to Bangalore, because he goes to a very dear friend of ours who's a very prominent surgeon, and he says, look, I don't know what to do. So they said, listen, you go and see that old man sitting in Delhi. He might do something for you. So here was my first challenge. And I said, all right. And I'm just showing you the extent of the problem. And this is the first clean check. And I said, all right, you can't tackle, hard appliances. So let's see if we can do something with Invisalign. This is the first clean check at the start, and this is what was envisaged as the finish before we went into restorations. And he had good compliance, and we started moving towards it. I started the case in 2018. We managed to upright the roots. We managed to keep that anterior incisor segment without fenestrations. That premaxillary segment was there. There's no fenestration of roots. We managed to upright the teeth. We managed to bring them together. And this is what he was when he came for his last refinement over a period of time. But ladies and gentlemen, hello, excuse me, it's 7 refinements, 100 aligners. So whoever told you it's simple, and I have a big fight, it takes a lot of effort from me to go back onto that clean check and insist, no, this is not going to work. You know what? The first set of for the cake, the difficulty of the case is send me a treatment plan with 36 aligners. And I said, excuse me, one aligner is supposed to give you 0.5 millimeters of movement. And would you please tell me how would I finish this case in 36 aligners? And then I went to Germany when I was doing incognito, and I learned how you have these young girls who are just technicians, not even trained technicians, who are sitting there with with their earphones and eating something, and they're playing with it, and they just treat a malocclusion like it's the easiest thing to do on the world face of the earth. But that is 100 aligners down the line, ladies and gentlemen. I've just done the final refinement. We'll take them into restorations. We've not sort of split the cleft. We managed to upright within the bone. The boy is very happy. He's going for a nasal reconsideration, and this is where we are today. So that's about it. What it also tells you is the occlusion. How many of us ever look at the occlusion or have the ability to look at the occlusion? Do you manage to balance it? Did we treat? Because I remember I insisted on getting occlusion taught to the orthodontists, and they fought with me, and I said, listen, we'll have to do lectures with the prosthodontist. But this is where it is. So this is how his occlusion evolved, and we looked at it every time that we need to create a biting platform. He needs to masticate. So this is the advantage. That there are precise questions about the accuracy. It's work in progress. You need multiple refinements. But you don't have to belong to a club. Let's take this whole controversial issue of temporomandibular disease is not associated with dental occlusion. Excuse me? There was no orthodontic cause because there was no evidence. Now here is a direct contradiction of evidence. Ladies and gentlemen, and here is where it is, but if there is evidence and you haven't found it, then let me introduce you to another patient of mine. She's in the US. She came to me. Again, failed orthodontics. You look at the crossbite. She had myofascial pain dysfunction. She had migraines. She had fibromyalgia. She was unable to chew for 3 years, and she was being treated by everyone. She just fetched up by mistake. Okay, and she was on amitriptyline. She had got a TMJ splint. She had 2 bouts of orthodontic therapy, and somebody left a crossbite on the left side, and there was an overhanging 7. And this is what her occlusion was. And you just look at the points where the occlusion was being hammered and the condyles were being distracted. And this is where she was maybe 10 months down the line. But it took 6 treatment plans to take away the interfering teeth. And that is what you started to realize, that with Invisalign, you could break up the treatment. You could move certain teeth, you could leave certain teeth intact, and you could sort of plan a treatment. And here she was. Symptoms gone. She called me from the US. She says, Doc, I ate a hamburger after 4 years in my life. So does occlusion matter, ladies and gentlemen? Do aligners have a role to play? Well, I'll leave it to you to judge. Because this whole thing about extractions and posterior positioning of condyles, has it created problems? Because every case I got was not a simple case. When you went for your first Invisalign, they said, start with the simple cases. I said, I don't have the luxury. Because 90% of my practice is based on people where other people have failed, and they come with pain and bilateral TMJ dysfunction, and like this young man. Okay, he's had bicuspid extractions, he can't eat, he can't focus on his studies, and he comes to me. And his past experience was a very bad dream. His father is a very senior bureaucrat in the government. And he came to me. I said, why didn't you go to elsewhere? He said, no, sir. We heard that you treat people like this. And here you are. Just have a look, ladies and gentlemen. This is orthodontics. Is this what we train our postgraduates for? Do we even teach them to be critical of what they do? Well, here you are. Have a look. And I'll take you through it because this was his problem. Because he had undertopped incisors, he had a mutilated occlusion, he had constricted lower canines, he had crowding in the segments, and we needed to create a problem. And this is how I built a program. And I have this big fight with Invisalign. About 6 treatment plans later, they start listening to me. That I needed an anti-clockwise rotation of the maxillary occlusal plane. I needed 3 millimeter vertical movement of the maxillary incisors, intrusion of the mandibular incisors, interpremolar arch width, torque of 10 degrees. And this is the complexity of digital treatment planning, ladies and gentlemen. To those of you who think you can just take an impression or a scan and send it to Invisalign and say, treat me, it doesn't work. You are an orthodontist. I wonder how do it yourself or work from home would work with direct to consumer. They just come in and we will fix it for you. How do you fix it? How do you fix it? Because you needed to look at the occlusal plane, and this is 47 sets of aligners. At 12 months, he went through refinements, and you can see this is where we started. Look at the reds on his occlusion, where the occlusion was hammering down and creating problems. And then you finally got the blues in place and you settled an occlusal platform. That's a learning. So it's not about the appliance, it's about recording the evidence and understanding what you can do with it and where do you take it. So here is the, there are no randomized controlled trials. There are cross correlations. There people are billing. There's one set of people who are trying to say it works, and they're mostly clinicians and marketing people. And the academia has spent its lifetime saying it's not been reformed, it doesn't work, it's no magic. But here's what the truth is, ladies and gentlemen: it's an appliance. The rules of diagnosis and treatment planning apply. Okay, it's more acceptable because it's not aesthetic. It does not interfere with food, speech, social context of the workplace, and direct to consumer market brings people into your practices directly. People come asking for Invisalign. Okay, so but have you looked at the fact that if you have a reduced biofilm in people with susceptible diseases, in kids with high Caries index sort of problems, and kids with subacute bacterial endocarditis, would they be a better way to treat because you would not have that accretion of bacteria? It's an open-ended question. So here we are, ladies and gentlemen, as I get towards the end of my. And this comes from the BMJ that evidence-based movement is in crisis. It is in crisis because the evidence quality mark has been usurped by vested interests. I just said it, the industry has taken it away from us. All right. The volume is unmanageable. You get so many studies, but you can't critique it, you can't study it. And the statistical significance is of no consequence in clinical practice because if you you can upright incisors by 30 degrees plus or minus. So which 30 are you going with? Positive or negative? There are inflexible rules in technology, and this is the whole crisis. And I'm so glad that from the stable of evidence-based healthcare comes the first critique that it's a movement in crisis. And I agree with them entirely. And I must tell you that this was great. This was great. One of the best and the most attractive randomized controlled trials which were offered. At one point of time, they went into the papers. They did not show the right-hand side picture. They said they want to test the efficacy of parachutes in preventing death and major trauma from jumping from aircrafts. It was a randomized controlled trial, and they looked for volunteers, and they're paying 50 pounds per head. This is absolute sort of cynical British humor, which was published in the BNJ, that it had people shocked. I heard from my colleagues in the UK, and they said, we'll take 100 people, 50 will jump with a parachute and 50 will jump without a parachute. And then we will have a randomized controlled trial, which was tell us that whether parachutes work or they didn't. So there was shock and awe, and people said, are you mad? And then they did the study, but except that they did it from the aircraft standing on the ground, like it's on the right-hand side. And this is classic to just show you that you cannot go with a randomized controlled trial everywhere. And that is going to be the biggest problem. So here is the challenge. And here is my next question, that if evidence does not support it, do you stop doing it? Well, I've been challenged on this many times because I made presentations. I was talking to Virendraji about, speaking at various pediatric meetings over this. So if you do not have an evidence base, you stop doing it. If you don't have an RCT, you stop doing it. So let me go back quickly to what do you do? If evidence contradicts established practice, what do you do? Or is this the reason for an opinion leader, KOL, direct to consumer approach? Or is this the reason why people turn to opinion and easy fix and quick cures when the voice of reason is drowned in slick marketing and demand, which is created by the industry around you? Now, here is what it is. Here is advocacy of a different kind. Here is somebody so important saying that this type of bracket is no more effective than conventional bracket, but has harm being caused. Should you de-implement these brackets? Well, there's no evidence to show you should implement or de-implement them unless you start creating the evidence. Okay? Let's look at the bread and butter of our teaching and our philosophy, growth modification. In 1967, the first randomized control trial that was published by Jacobson said that you cannot modify growth. You can tip teeth. You can mold dentoalveolar segments. The evidence was clear that headgears, there's no evidence, and the potential risks would far outweigh the benefits, if any. But yet, please look at this. We continue to practice this. We continue to teach it. It's central to a postgraduate examination. If you can't make a functional appliance, even if you don't have an ideal case, and I've heard this litany now for 20 years that you're looking at an exam, so there's no ideal case. Okay, never mind. Tell him to bring it because the examiners will want to see a twin block or a activator the banado. Excuse me. Is this what we need to do? So let's look at this. Let's go from here. This would be challenging, but here you are. 1967. No support for mandibular shift or condylar growth. Jacobson. All right. Let's look on this, and I wrote a lot of commentaries on this. This is published in 2003, a twin block appliance, and the clinical bottom line. And I'm giving you the strength of the evidence. It's fairly strong. You look at those arrows that just shows you how you quantify according to the evidence-based perspective. Early treatment with twin block is effective in reducing overjet and severity, but the skeletal change is not clinically significant. All right. Let's look at this famous story by Tulloch, Profit, and Phillips, outcome in a two-phase randomized controlled trial, 2004. Early treatment is effective but not efficient, and if there are any morphological differences, they completely disappear by the time you get into a comprehensive treatment. So should you be putting a plastic king in the mouth of children? This is an open question. All right, here is a study which was published much later. It's a meta-analysis. And it says that there was a statistically significant difference of 1.79 millimeters in mandibular growth in the treatment group with compared to the control group. 1.79 millimeters. Well, we can argue that it's very, very significant. I mean, to some people, a millimeter makes a difference, but there is no advantage on a two-phase treatment over a one-phase treatment. And if you use a functional appliance in the earlier adolescence, there are small beneficial changes in skeletal pattern, but these are probably not clinically significant. So should we persist in doing it? Here's another story. 2014, I just went through the thing. What did the twin block do? This is a systematic review and meta-analysis published in the European Journal. It tipped incisors, corrected molars, no significant skeletal change. The level of evidence is limited. Here it is from the Cochrane database, and that's my commentary, which I wrote in the evidence-based dentistry journal, that no functional appliance is better than the other. There's no change in the skeletal pattern. And when you treat a child for class 2, it's more effective in reducing incisal trauma. But by the time you get the child at the age of 13, the incisal trauma has already taken place. So it's up to the pediatric dentist to send them to you or treat them. Let's take, one or two cases. What do you do with a case like this? A classic case. You say, all right, you take him on it's a slightly vertical tendency, and you look at the overgrowth and you say, no, it's not good. But then, you have to look at the upward tipped palatal plate. Is this an ideal case for a twin block? No, it isn't. Have a look at the cephalometrics. But here you are, but you have to do something. So you throw an appliance, and 8 months later, the child is like this. Well, changes have taken place. Certainly they've taken place. Most efficiently they've taken place. But did you get any skeletal growth? Oops, nothing. Did you get a slight open bite in the anterior region? Yes, of course, because you did hammer in the occlusion at the back and you got a chain. Now, is this going to be stable? Or you take somebody like this with a simple lip trap. Is this a better way of doing it? That you just jump it and you let the child grow into it? Okay. So these are the challenges. So here's my take before I get hammered into the ground that are you saying we shouldn't practice functional appliances? Well, you need to be selective. You need to know in which cases are they going to work, in which cases they're not going to work, and if they work, how far would they work, and is it not better to do something like this? 13 years of age, decision. She was brought in, and I remember taking a decision on this saying, rubbish. Take out bicuspids. I looked at a family, we took out bicuspids, we treated her, we went through the treatment, and this is where we finished. There's nothing spectacular, but this is how she grew. Is this the outcome that you want to know? Which case will grow into a good profile and which case is going to remain stunted? And where do you need to go in with it? But this is the answer that we are looking for today. And evidence has not been able to provide it. Data will. In 2 years, she grew. How could you take a call? Till you could do a genetic typing that you knew that there was going to be no deficiency. If she had stayed with a short mandible and low anterior face height, she wouldn't have looked good, and then you would have regretted that I didn't do anything at all. So this is what the evidence says today, that it's mostly the mandible. There's a very small environmental component. It's mostly genetic. No orthodontist or dentist can grow a mandible. Functional appliances do not change skeletal relationships to a meaningful degree. They do correct incisal relationships. They improve facial self-esteem. There's no trauma, but by the time the patient comes to the orthodontist, the trauma is already taking place, and a two-phase treatment may not work. Extracting premolars and using elastics, which we suddenly have forgotten that, the class 2 elastic has great strength, and we want to go in for hammering occlusion with heavy, fixed functional appliances, and we teach people and create open bites and let it go. So this is where we are coming to answering uncertainty, and this is where the world of medicine and I hope the world of dentistry will change, and this is where orthodontics will change, and we have to come to deep learning and the real world evidence. And there are multiple pathways. Because I think what is the problem with us is we've arranged ourselves to confirm the wisdom of our decisions. If we want to use a self-ligated appliance to expand teeth, we will say this is the best way to do it. The outcome matters, what works, when, and in which case, with which appliance. This is what you would like to know before you got a patient to your clinic and you wanted to give an option to the parents and say, I'll give you a 100% guarantee it works. And that, ladies and gentlemen, we are very, very close, because I think we'll have to change the mindset, because there is a mind that is more complex than the body, and orthodontics is highly individualized, right? You need soft tissue, you need soft skills. The appliance is not the end. The patient is the end. He needs to be addressed to, or she needs to be addressed to. So have this whole sort of reams of data that we published, if they did not fit into an evidence-based perspective, has it changed anything? Or no? Because a profession cannot be driven by appliances or techniques, and this is what science is doing. So you need to measure it. And if you can measure it, you have a key. You need electronic records. And let me show you what is already happening in the world. And this is a brilliant critique and analysis of extraction versus non-extraction, of building a predictive thing from 350 patients. All right. The point is that you take the data, you want to decide whether you extract or you don't extract. And then if you extract, what is the anchorage back? Okay, and this is how you work with artificial intelligence. I'm sorry, it's not about reading cephalograms and predicting. This is where the whole challenge is coming in, that you feed in the inputs and you look at the outcomes, and then you're going to get a prompt somewhere that in this case, with this aid, this SNA, this SNB, this nasolabial angle, this upper lip to E-plane, lower lip or lip competence, you extract all the fours, you extract all the upper fours and the lower fives, or you take out the fives and you take out the others, and it also tells you what is your anchorage back. This is the learning which is going to come from your data within your practice. You don't need to look for some other source to give it to you. If you can crunch your data, if you can go back and do it, and today there is this great ability to crunch data because this is clinical decision support. Now I'm showing it to you. It's happening around the world as we speak because this is, you have a new case, you take the standard set of 24 features, you feed it in, and you're going to get a prompt saying that what is the likely pattern that's going to emerge on this case. That's because you need to take the time to record it and you need to understand it. This is called clinical decision support. A lot of work we're doing with my AI, this thing in diabetes and others is now coming to sort of giving you clear indications and hints as a doctor that when you do it, it says warning, this will not work, or warning, this will work. This is the future, ladies and gentlemen. You have to mine data. Some of us are going to have to do this hard work of putting down data and then running it through AI network, through machine learning, and this is what you're going to get at the end. I think that is the future, ladies and gentlemen. Because orthodontics will change and adapt, we all do. And I think I made a candid point and I may have upset a few people, so I apologize if I hit out at the business science of orthodontics to say it's time to come back to orthodontic fundamentals because you matter, not the technology. You use the technology. And I think the word is being valuable because as practices limp back, money is short supply. If you cannot convince the patient of the value of your treatment and how you do it, you're not going to get the treatment. So this whole business of orthodontics will see a transformational change. I'm just hoping that this pandemic has reset the button on this whole sort of industry and market-driven story that has overtaken us. They own us, ladies and gentlemen. Where is our own professional ethos and our standing? Why do we want to be owned by industry? You need to tell them what you need and they need to give you. You need to work with them. They need to answer your questions. But can you be dictated entirely? I'm afraid that is it. This is the future, mechanobiology. This is what we need to look at in our fundamental dissertations, in our research. It's the intersection of biology, mechanics, and morphology. It's about defining the individual and creating individualized treatment plans. I've just shown you, if you can do it with an aligner, there are many platforms available today. There's a desperate need, and I'm saying it again, to introduce fundamentals of bone biology, genetics, and principles of regenerative medicine into orthodontic teaching and practice. We haven't done it. We just cursively skim through it because industry-driven advances will not further precision orthodontics. To do that, you will have to understand the individual, you'll have to predict the outcomes, and then use and apply this which works. This is the future, ladies and gentlemen. This is where it's coming. That you hopefully will have a molecular analysis and you will be able to use specific biologics or pharmacologics. You will be able to use accelerators. Okay? You will be able to build custom-built appliances, ladies and gentlemen. As I speak to you, this is happening around the globe. It's missing in our orthodontics here, and we've got great skills at our hands. We can really do this. It's not a problem. Because this is what's going to happen, and the industry doesn't need to be worried because we have to use appliances, we have to use materials. We're not going to waste time on using our material science. So here's the story, ladies and gentlemen. 2020 vaccines are available. Probability was 10% that we would throw everything and we'd be ready to travel, but the vaccines are evolving, and it's a 60% probability that by till the end of next year, nothing radical is going to happen. And I'm not being pessimistic that the waves will carry on. We're doing very well, and I only hope we evolve. And there is also this whole paradox of thrift that, what it costs you to provide a treatment, what the patient has to pay, where are you going to? Because you need to carefully consider the technology and material science. It's not about selling brackets or treatments. And this was Hippocrates, and I think it's most relevant to orthodontics. And that fits in specifically with malocclusion. It's more important to know what person has the disease than what disease has the person. It's more important to know what individual has the malocclusion than what malocclusion the person has. A class 2 can have 100 ramifications if you go beyond the age of 40 or 45. Today, most people are using 5 categories of drugs at the age of 45 to 50, and you're starting cases. Do they affect your ability to move teeth? You ever thought about it? Where do you need acceleration? Where does it work? Which patient is going to respond? How many autoimmune disorder cases are coming into your practices? I think that is the challenge. Very interesting. These are some lessons which the UNICEF young reporters learned from the pandemic, that you have to live every day, but you have to choose the path you take. We are fragile, and the strength lies in being part of the community. So I think we need to strengthen ourselves as an orthodontic community. And it teaches you to love, to care, to respect, and to help. And of course, you can be like me. You can be productively stupid who over 40 years has bumbled along, and I have no hesitation in saying that the dream I started with evidence-based stuff that I will change the world. It never worked, ladies and gentlemen. But then I learned, because it's good to be stupid like me, because then you want to do other things. Because if you're so convinced that you're brilliant and bright, then you're never going to look for it. So the question is, do you want to learn from what other people discovered, or you want to make your own discovery? So I'm stupid. I openly accept it, ladies and gentlemen. I'm very proud of it. So thank you very much. And I would be failing in my duties if I did not thank the Dental Council of India, the EC, Dr. Anil Chandna, for having pushed me. And I remember telling him that, Dr. Chandna, are you sure you want me to speak on this platform? Because you're not sure what I'm going to speak. And even I might contradict or conflict. I hope I haven't hurt some sentiments, but I thought it's better to be candid. I must thank Dr. Srikrishna for being here, for moderating this discussion. And I must thank Mukesh, with whom I've interacted after so long at the Dental Council, and Virendraji, who's done a great job. So with grateful thanks, if I have questions, I will answer. If you want to write to me, please write to me. These opinions expressed are mine, and they are based on science. And there's no miracle or religion or belief here. It's all science. Thank you. God bless you. Stay safe, and Jai Hind.
Sir, really, that's a great presentation, deep into the evidence. Sir, there are a few questions and answers, questions from the audience, from the attendees. Should we go ahead, sir?
Please do. Please do. We are happy to answer.
So there is a question from gentleman. Can malocclusion always be associated with genetics and gene-related factors?
The current evidence is that the contribution of environment is limited. It's largely a genetic issue. And if you go back to Bill Prophet's article of 87, he said that this is something we need to analyze and work with, because if it is genetic, then you're likely to go with extractions, with radical alterations. And if it's environmental, you may be able to work with functional appliances and modify the environment to correct it. But the contribution of genetics is very large in malocclusions.
So, second question is orthodontics branch affected more with COVID-19 as compared to endodontics and other branches?
I would accept that. We are affected more because, for one, we were made irrelevant at the beginning of the pandemic, and we've come back to it. And the endodontists and other branches, since you need to eat food and you have pain and you're addressing crucial issues, it tends to be more important. But nobody has taken the perspective in a larger context, and that I said, you have to be valuable. You will have to shift your marketing from just promoting good smiles to being a part of mainstream healthcare. That your ability to breathe, your ability to chew, your ability. I've shown you cases who came with extreme problems, which were basically rooted in bad orthodontics. So I think we've taken a hit, but we'll need to reform. We'll have to come back. But we'll have to recast ourselves. We cannot be a cosmetic profession. We cannot just sell smiles, because you wear a mask in any case. So if you cannot address the fundamental issue of a patient, that if he has pain, he has problem with his joints, or he has problem with his own psyche, or you need to dig deep, now, ladies and gentlemen, to justify your treatment. So we have been affected, and we've been affected quite seriously and severely.
Sir, the next question is, what is your view on development of machine learning, that is AI, in orthodontics to diminish human error in diagnosis?
I don't think it's about diminishing human error, because no machine can substitute the human brain. You are to be at the center of this, and you will have to what artificial intelligence or machine learning can do is to give you a feedback from the data that you generate, which can give you correctives. The decision is going to lie with you, ladies and gentlemen. It's at the center. You're at the center. What is being built is the ability to look at large volumes of data and provide you with a clinical decision support system. So it's about your decisions would probably have a better sort of scientific basis if you look at artificial intelligence and machine learning. Then I've just shown it to you how we take decisions. It's by the rule of the thumb. We've already decided. You see a patient, you've already decided what you're going to do.
So the next one is, sir, so basically we need to evolve ourselves apart from bookish knowledge.
Absolutely, because you need to question the bookish knowledge. And please remember, by the time you read a book, it's 8 years out of date. So we need to, I think what I would like to say is that the fundamental requirement today is to create healthy skepticism in science. Because unless you're a skeptic, as a student, as a practitioner, you will not ask questions. And if you don't ask questions, you're not likely to improve because you're likely to put on the way. So I think we need to recast ourselves. We need to look at a fresh approach to this entire process of teaching and learning orthodontics and practicing.
So the next one is, what is Orthodox Christian?
You've got me, sir. I'll have to go down and read it and come back. If you know about it, please give us the answers, because there are lots of people in this presentation. So I'm really at a loss, but I will look into it. I'm not going to comment on it because I haven't heard about it.
The next one is, sir, how to improve the patient flow in the clinic, as there are already a lot of clinics in the market? A general question, sir.
Listen, I told you, the differentiator is going to be, are you just available or are you valuable? I made this point. You have to define yourself at the center of improving not just the aesthetics, but contributing to the overall health of the patient, and then you would be there. So I think I have a very simple message that you can be in a marketplace with 200 people, but are you the most valuable orthodontist? Do you have the soft skills? Do you address the needs of the patient in terms of the soft skills that you require, the empathy, understanding the patient, working with the limitations of the patient, his genetics? If you can individualize and personalize to that, you will come out clean ahead of all others. Because everybody else says, sir, wo fixed ka, ceramic brackets, he charges 10,000. For removal, for metal brackets, he charges 8,000. Hello, the complexity of the case may be bloody intense. Are you going to do that case for 8,000 bucks? Or it again brings us back to big discussion. Do you sell brackets in your practice, or do you sell your diagnosis, your inputs, your consideration, your treatment plan? The day you can do that, ladies and gentlemen, you are going to come out in the center. Because please, that's my humble request, would you please stop selling brackets in your practice? That if we do metal for 10,000, we do ceramic for 15,000. Hello, excuse me, what does it have to do? The question is, what is the severity of the malocclusion? What is the complexity? What is it going to take for you to reach from point A to point B? Is that the change? So that is a fundamental change in mental attitude that we're going to have to bring about in orthodontics if you want to succeed in the marketplace. So I charge 25,000 for a treatment plan. If you want to get treated by me, I'm going to absorb it in the total cost of the treatment. You want to go away, I'm not going to waste time over 3, 4, 5 days analyzing it and give it to you. You first deposit 25 grand and that's mine. Simple. What brackets you want to use is your choice. That's the way I've been doing it. That you tell me, you want ceramics, I'll give you ceramics. I think you may benefit from self-ligation, so I'm not going to charge you extra. I'm going to cover it in my cost. And if I think that you do better with aligners, I'm going to just tell you that, look, these are the pros and cons. You wanted me to do it conventionally, this is how I do it. That's it.
So the next one is, evidence is always right or not?
I said it. You need to question evidence. There are 5 A's of evidence, You ask, you acquire, you appraise, you audit and apply. It's very shocking when you look at the evidence which is available on Cochrane sites. None of them addresses direct clinical problems. So you cannot accept evidence, and we went through this trying to teach people how to critically appraise evidence, create CATs, and go through systematic reviews. But I think we are at the brink of what the world is calling real world evidence, that you record evidence in a certain standard format electronically, and the machine at the back is already analyzing your numbers, and it's giving you what's called real world evidence. This is the new normal. It's called deep learning, deep medicine, and real world evidence.
So the next one is how to manage patients with high caries index undergoing orthodontic treatment.
So one is that you do not start orthodontic treatment till you have a clearance from a concerned specialist like my friend Virender that the caries is under control, because it's going to kill you if you carry on sticking brackets onto teeth. The second thing is that today you have the option. When I got into customized lingual, one of the things I used to recommend to people is that if you had a high caries index, we would recommend lingual, because it has been found that the lingual does not cause caries on the inner side of the mouth. And today I would happily go with the aligners and say, listen, the child has a high caries index. I'm going to switch you to aligners, because you can remove them, he can brush his teeth and take them back. But you need to control the caries before you put brackets in the mouth, or you've got liability. White spot lesions, I hope Dr. Sridev is here. She's the expert. And today we are talking about prebiotics and probiotics in controlling all this. So again, you're looking much deeper. Prebiotics, probiotics, caries control before you touch the patient for orthodontics.
So the next one is, sir, what is your take on videos people who are practicing orthodontics with the help of aligners?
Sir, it doesn't work. I've shown you it's a lost cause. The first couple of cases are getting into courts. And frankly, I mean, I don't think we should go and fight them, because there's nothing which stops them from doing it. It's going to be only the learning which is going to come from the patient, that he's not, as I said, most of my practice is failures. I've shown you. So I think it's a very complex question, and it's not something that happens only here, because I've been fortunate to lecture around the world, and wherever you go, I'm asked the same question: that what do you do with this do-it-yourself orthodontics? And I quoted the CEO of Invisalign saying that we have the best way to straighten crooked teeth. So where's occlusion, TMJ, functional matrices? It's so, to make yourself valuable, you will have to give more to the patient than just sort of saying that he can go and order brackets and settle his teeth. Until occlusal interferences can kill the patient with TMJ problems.
Another general question, sir. What is the best suitable age for starting orthodontic treatment? Many times we have come across, sir, but still for the public.
So if you have, I would say the ideal thing would be to have a look at 8 years, and any time. If you have a crossbite, the moment you see it, please correct it and leave the patient alone. So, and as long as you can see it, because at that critical age, if there is a deflection of the mandible, on a crossbite, and you wait for it to mature, then what's going to happen is that one side of the condyle is going to get distracted and the other is going to grow. So you'll land up with a skeleton. So correct it when you see it. That's one. Second is, I think 8 years is a good time for anybody to take a call to see if there are any functional shifts, if there are any habits which are detrimental, to see how the genetics is evolving. You may start treatment, you may not. But if you have a look at the age of 8, you'll generally get a good idea where the patient is heading.
Sir, there are a lot of hundreds of questions, but last question, one more question we'll take, sir, because lack of time. Sir, what would be your opinion on the concept of orthotropics put forward by Dr. Mew, where they really push removable appliance-based treatments, where he faced a lot of criticism from orthodontists? Would we look at it more acceptable fashion now?
So the question is, you question what he's doing, you look at the science behind it, and do not pass judgment till you have some evidence on it. You wish to use removable appliances, please do it. But please understand the limitations that you're going to get. And at the end of the day, you need to know, what do you need to do for the child or the patient? Orthotropics, the problem is that people want to build a religion around a technique. So the technique also, even if there's 10% good, it tends to fall into a big, deep ditch, which is unfortunate. So I would say, look at orthotropics with a skeptical mind, question it, be curious about it, think about the fundamental principles, apply scientific knowledge to those fundamental principles. If it works for your patient, try it. If it works, you record it. If it doesn't work, well, as I said, nobody ever died of a class 2 molar here. You know, nobody ever died of a class 2 molar. So you have that option.
Sir, with that, we'd like to end the question and answer session. Anything would you like to say, sir?
No, but thank you so much. And I'm so grateful. I've said it before. So let me thank the Dental Council, the EC, and my friend and colleague Anil Chandna, Srikrishna. Thank you for anchoring this. Mukesh ji and Virendra Goyal and everybody behind who sort of put this whole thing together and helped me sort of present it. So grateful. And I said, again, stay safe, and the vaccine is here. So let's look at 2021 as a year of hope. So thank you. God bless you, and Jai Hind.
Thank you, sir. I want to thank Dr. Kalha, sir, on behalf of Dental Council of India for an excellent talk. The best thing can happen to all the dental surgeons of India at this COVID time is knowledge gaining and knowledge sharing. This happened only because of our council's foresight. Thank you. Thank you, sir. We would like to mention again here the highest number of attendees in the last webinar. Hundreds of colleges took part in the past 20 webinars conducted by our prestigious Dental Council of India. Out of them, the main 5 colleges are the Savita Dental College and Hospital, Chennai, Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, Jannaik Devilal Dental College, Sirsa, Saraswati Dental College, Lucknow, Mahatma Gandhi Missions Dental College, Navi Mumbai. Highest participants from this college, attendees from this college, and many colleges, many attendees have took part. We expect them to come up also to these colleges level and cross them. In the next webinar, hopefully we see their names also. Thank you for participating, appreciate them. And our next webinar is going to be on 31st January. Please notice next week there is no webinar. Next week there is going to be a webinar, that is 31st January 2021, Sunday at 4 p.m. as usual. Our next presenter is going to be Dr. Ajay, sir, and moderator is going to be Dr. Karnakar. And the topic is going to be electronic working length determination, clinical tips and troubleshooting on endodontics. It's very nice. And I would like to thank our acting president, sir, executive committee members, dental council members, office bearers, Mukesh ji, Dr. Virendra Singh Goyal ji, for giving me this opportunity to be the moderator. And thank you all the participants for taking active part, all the attendees. We'll be looking forward for you to take part in the next webinar on 31st. Thank you, one and all. Jai Hind.